Hello dosto, welcome to Grow Med. So I had posted a video on the biochemistry regarding the revision, okay, like the quick revision video, and most of you have found it useful, and also I was getting DMs and comment regarding it that do it for other subject also. And most of you wanted it for the obstetrics and the gynecology. So I am starting that revision session for the obs and the gyne. First, we will discuss the topics from the obstetrics, and after that, we will move on to the gynecology. So it will be like a quick video, about 20 to 30 minute video, okay, in which we will be discussing about the diseases, then type of question asked in the FMG, everything in a quick manner, so that it will help you all in the revision. Because revision is the most important part, and also most of you find it difficult during the revisions, okay. तो ऐसा रहता है कि जो कंटेंट पढ़ा है थोड़ा सा याद है, थोड़ा सा भूल गए हैं, एंड वो रिदम नहीं आ पा रहा है, ठीक है. सो फिर से पूरे वीडियोस देखने का टाइम नहीं है क्योंकि इट विल बी टाइम कंज्यूमिंग. सो व्हाट यू ऑल कैन डू इज़ वॉच दिस रिविजन सेशन. In 20-30 minutes there will be quick recall of the things, and later that you read the notes. So it will be time saving also for you all, and also you will be able to recall the things easily. So this is the part 1 video of the revision. Subsequently I will be sharing the part 2, 3, 4 videos, okay. So let's start our discussion. So the most important thing from the gynecology, from the obstetrics, is the labor, okay. So labor, you can expect one question from here. The questions are asked on the stages, okay. Then the presentation associated with it, the presenting part, the lie, everything, okay. So we will look at those things quickly. So labor, it is classified into the 4 phases, okay. So let me say you about the phases. That is not much important, but still we will look at it so that it will be clear to you and it will not be confusing in the future, okay. So there are 4 phases, and the phase 1, it is the dormant phase, in which throughout the pregnancy stays, okay. That is the dormant phase. So you can remember it like the 9 months. So jitne bhi duration hai pregnancy ki, that is called as the dormant phase. Then the phase 2 is the preparation phase. Then 3 is the process phase. So the third process, the third phase, which is the process, it is classified into the 4 stages. So questions are usually asked on these stages. So you need to learn about these stages. This is just to make you clear about the things so that you do not get confused. And the fourth process is the puerperium, which is the process after delivery, जब female body normal physiological process में जाने लगती है, okay. So these were the 4 phases. So questions are asked on the stages, so we will discuss about the stages. So the stage 1 begins from the contraction of the uterus, and the stage 1, it is from the contraction of the uterus till the cervical dilatation. Then the stage 2 is the full cervical dilatation, and from there till the delivery of the fetus. It is called as the stage 2. And stage 3 is delivery of the fetus. After the delivery of the fetus, till the delivery of the placenta. This is called as the stage 3, and the stage 4 is 1 hour observation. So these stages you need to remember what stage stands for which process, okay. This stage 1, it is again classified into latent phase and the active phase. So here you can see in this image the latent phase and the active phase. The active phase is again classified into the acceleration phase, phase of maximum slope, deceleration, and then the second stage, okay. So you just need to remember, there's no need to mug up all these things. It's just that you need to have an idea about these things, okay. Then so questions are asked on the time duration, that how much time duration for the stages is normal, and if it is prolonged, and after what time duration it will be called as a prolonged stage of the labor. So we will look at the normal values first. So the normal value of the latent phase is 8 hours, and for the active phase it will be 4 to 6 hours, and for the stage 2 it is 2 hours for the nullipara and 30 minutes for the multipara. So delivery of the placenta 15 minutes, the normal value, and 1 hour observation, okay. So when do we call it as prolonged? We will look at those values now. So prolonged first stage in nullipara if it is more than 20 hours, and in multipara if it is 14 hours. You need to remember these values because these are asked as a question. So these were all PYQs, so you need to remember these things. Then also questions are asked on the rate of the cervical dilation and the rate of the descent. So in nullipara, these values are the normal value. If these are normal, then you can progress with the delivery, and if these values are not normal, then there will be a rest of the labor and a rest of descent. So we will look at those things also now. So the rate of dilatation in a nullipara, it should be 1 centimeter per hour, and in multipara 1.5 centimeter per hour. And the rate of descent means the fetal skull. So how much the fetal skull is coming down, that will be called as the rate of descent. And in nullipara it is 1 centimeter per hour, multipara 2 centimeter per hour. So there are some conditions associated with this abnormal labor, like the arrest of descent. We call it arrest of descent when there is no descent for more than 2 hours. Then the dystocia, anything that causes obstruction in the labor, that is called as the dystocia, like for example shoulder dystocia. Then the arrest of labor when there is no cervical dilation for 2 to 4 hours, then it is called as the arrest of labor. So these things can be asked like giving one liner, or also maybe a clinical case, like they'll be describing the things that a female in the labor, contractions are good, there is descent but there is no cervical dilatation for more than 1 hour. What will be the diagnosis? So it will be arrest of dilation. Then similarly the question can be asked on the dystocia or the arrest of labor. So this was about the stages of the labor. There's another important thing from the stages of the labor which you must remember, and it is that in the latent phase we can give the tocolytics. So these tocolytics, they are the uterine relaxants, and these will relax the uterus if at all it is less than 34 weeks. If it is less than 34 weeks, then only we will be giving the tocolytics just to get some hours to gain the lung maturity of the baby. So if it is more than 34 weeks, then we will be progressing with the labor, because the fetal lung maturity will be attained by 34 weeks. At that time there is no need to give the tocolytics. Then moving on, so we will discuss now the other things like the presentation, presenting part, lie, everything. Okay, so the fetal presentation, it is classified into the cephalic, breech and the shoulder. So cephalic means this, the head will be the presenting part, and the cephalic, this is the most common presentation, and this one is considered to be the normal. Okay, so if it is cephalic, then the delivery can be conducted very easily. Then another type is the breech, and this is the most common mal presentation. So it is not normal, and you can see here in the image that this is the breech presentation. And the shoulder presentation, this one, as you can see here, the shoulder will be the presenting part. Then moving on to the presenting part, then based on the presenting part, it is classified into the vertex, brow, face and brow. So the vertex means the head will be the presenting part, and the face means the face will be the presenting part, as you can see here in this image. And the brow presentation means the deflexed head. So questions are asked on the attitude of the baby, then the diameter, engaging diameter, and how will you manage this patient? How will you manage these things, like whether you will be going with the vaginal delivery or doing the cesarean section. Okay, so this vertex means it is the most common and it is the normal presentation. Okay, so in this kind we will be doing the vaginal delivery. And the questions are asked on the engaging diameter, which will be the 9.5 centimeter, and it will be the suboccipito-brygmatic. So we will discuss about these things, the diameter, pelvis diameter, later in this video. Okay, then you will come to know these things easily. Then the face presentation, the diameter of engagement, if it is submentobrygmatic, then it will be 9.5 centimeter, and if it is submentovertical, then it will be 10 centimeter. Then the attitude of the baby will be the extended head. Okay, so the head will be in the extended form. Then moving on to the brow presentation, so the brow diameter of engagement is the mento vertical, which is the 14 centimeter, and this becomes a large diameter. So this diameter cannot pass through the female pelvis, so we need to do the cesarean section for it. And as we have discussed, the attitude, it is the deflexed head. Okay, so for now just remember these things, the vertex, face and brow, because when we will discuss about the pelvic diameters, here we will be discussing about the pelvic diameters, then you will be easily able to understand these things like the diameters. Okay, then based on the lie, it is classified as the transverse and the vertical. So the transverse means this lie, which is the shoulder, so it is the transverse lie, and we need to do the cesarean section for it. And these are the vertical, so we will be doing the vaginal delivery. Then moving on, we will discuss about the types of the breech presentation, because image based questions are asked on this. So any of the image will be given and they will ask you which type of breech presentation it is. Okay, so the image, first image, the extended breech in which the legs are extended. So this is also called as the frank breech. Okay, then the complete breech, then the flexed breech, and then the footling breech. So as you can see here that one leg is coming out, it is called as the footling breech. So in this extended breech, you can see that the hip is flexed, flexion of the hip, and the knees, they are in the extended. And in this complete, both the hip as well as the knee, they are in a flexed form. Flexion of both of these is there, and then in the flexed, So for the flexed breech also it is the same. The hip and the knee, they'll be present in the flexion, and the foot link means both the hip and the knee, they are extended. Okay, so these were a few types about the breech presentation. Then moving on, the questions are asked on the cardinal movement. So this year also in the Jan 24 there was this question, and questions are asked on the sequence. So you need to remember the things in the sequence, that which comes first, which comes later. Okay, so the sequence is, first there will be engagement of the head, then the descent of the head, then flexion, then internal rotation, then again extension, resuscitation, and then external rotation. So images also you can see here: engagement, flexion, then descent, rotation, complete rotation, complete extension, then resuscitation, anterior shoulder delivery, and then later posterior shoulder delivery. Then moving on, as we are discussing about the labor, so we will also discuss about a few important things like the antepartum fetal surveillance and the intrapartum fetal surveillance, what all we will be doing and how we will be doing it. So in the antepartum fetal surveillance, the things which are checked are the daily fetal movement count, then the non-stress test, then the BPP, which is the biophysical profile, and questions are asked on the components of this BPP. So this one is a PYQ. So they will give 4-5 things, and they'll ask which of the following is not a component of the BPP, or which of the following is included in the components of the BPP. Okay, so it will be including non-stress test, then the fetal movement, fetal tone, fetal breathing, and the amniotic fluid index. Likewise, there's another parameter called as modified biophysical profile, in which there will be a non-stress test and amniotic fluid index. So this is also asked in the past year, that the modified biophysical profile includes which of the following. Okay, then the next is the Doppler. So we will be doing the Doppler of the umbilical artery and the uterine artery. So image is also important, because image based questions are asked on this Doppler finding. So the normal is this one: uniform flow of the systolic and the diastolic blood. So this one here is the systolic, and this one here is the diastolic. Then the second image, as you can see here, that this notch, it is a little bit lengthy, and also you can appreciate something notches like this. In this image it is not there, but it can also be like this. This finding also is associated with the reduced end diastolic velocity, means there is the compromised blood flow to the fetus. And in the third image, as you can see here, that the notch, it is touching the line, okay, like this. So this one indicates absent end diastolic velocity, that means severe compromised blood flow. And the fourth image, this image reversed end diastolic velocity. As you can see here, that the diastolic blood, it is going beyond the normal line, and this suggests there is the death of the fetus. Okay, so you need to remember the images as well as the condition when this image is can be seen. Okay, then the other two important findings which we do in this are the VAST, vibroacoustic stimulation testing. In this test, there are vibrations given to the mother, and due to these vibrations, the baby will wake up from the sleep, and its heart rate will increase. So this test is called as the vibroacoustic stimulation test. And the another important test is the contraction stress test, or the oxytocin challenge test. So this test is used to assess the possibility of the normal delivery in an IUGR baby. Okay, so in an IUGR baby, how much possibility is there that it can be delivered vaginally, that we can come to know by using this test. So in this, oxytocin is administered, and we will be looking at the fetal heart rate with respect to the uterine contractions. So if the contractions causes decrease in the heart rate of the baby, then we will be not doing the normal delivery. And if the contractions, they do not cause change in the heart rate, then we can go with the normal delivery. So these were the things which we will be doing in the antepartum fetal surveillance. Then moving on to the intrapartum fetal heart rate monitoring. So the things which you must know is that we will be calculating the fetal heart rate using stethoscope or the Doppler. Then fetal scalp pH, it should be more than 7.2, and a fetal ECG by using the cardiotocography. And this one is the best parameter. So can be asked as a one-liner that which of the following is the best parameter to assess the intrafetal heart rate monitoring, and it is the cardiotocography. So in this test we can see various decelerations, and they are the early, late, and the variable. So this early deceleration, so the etiology is given here, that it is associated with the fetal head compression, and in the active labor it can be normal. Okay, so what happens in this early deceleration is that you can see here, so this is the contraction, the peak is called as the nadir, and this one is the fetal heart rate. So the fetal heart rate, as you can see here, that the onset is before the onset of the contraction, and recovery is also before the contraction completes. So in corresponding to the contraction, the heart rate will be early, so it is called as the early deceleration. Then the late deceleration, it is associated with the uteroplacental insufficiency, and you can see here the uterine contraction, whereas the fetal heart rate, it is late onset and recovery is also late. And the variable deceleration, it is associated with the cord compression or oligohydramnios and the cord prolapse. So they can be variable heart rate decelerations, like for example, if this is the contraction, so they can be like this fetal heart rate. So the fetal heart rate will not be matching with the contraction, due to which it is called as the variable deceleration. So questions are asked on the etiology, like the early deceleration is associated with which of the following, or they can also give these images and ask you which kind of deceleration it is. So this one is very important topic and it is a PYQ. So you need to look at all these points. Then moving on to the partogram. So this is a graph which is plotted in the active phase of the labor, and we can come to know various points from this, like the cervical dilatation, then the rate of the descent of the head, then the contraction, how much strong they are, and the time of the contraction, then fetal heart rate, and whether we have given any drugs or no, like the oxytocin. Everything is plotted in this graph, and it helps us to come to know various things, like is the progress of the labor fast, or there is any obstruction in the labor, everything. Okay, and in this graph you can see here that there are two lines, the alert line and the action line. The alert line and the action line, and there is 4 hour gap present in between them. And whenever we are plotting this partogram, the line should be before the line of the alert. Okay, if it is present here, then it will be the normal condition, but if it crosses the alert line, then we need to take the action. Alert line represents the mean rate of slowest progress of labor, and action means appropriate action should be taken. Okay, so these were the things which you must remember from the partogram. Then moving on, we will discuss now about the type of the pelvis and their diameter. So this pelvis, this one is very important topic and a repeat topic, because questions are frequently asked on this, mainly the images. So you need to look at the images also. So there are 4 types of the pelvis, and the first type, the gynecoid, which is most common, it's seen in the females, and you can see here that the inlet is round, and by looking at this you can differentiate it from the others. Okay, so the anterior posterior diameter, it appears to be equal. And questions are also asked, like which kind of presentation is seen in which type of pelvis. Okay, so the occipital anterior presentation is seen with the gynecoid pelvis. So let me explain this to you. So this one is the pelvis. Okay, and the pelvis, these are the anterior, the posterior, the right and the left. So the occiput of the baby, it is anterior in relation to the pelvis, then it will be called as the occipital anterior presentation. Okay, then the next type, which is the android pelvis, and it is the male type of the pelvis, and the inlet is triangular in shape, as you can see here. Then the type of presentation which can be seen with this is the occipito-posterior. That means this is the posterior and this one is the anterior. The occiput will be present here. The occiput, it will be present in posterior in relation with the pelvis. And also occiput transverse means this one is the baby head, and the occiput, it can be transverse. And the complication we can see is the deep transverse arrest, because the engaging diameter, it will become more, and also the diameter of the pelvis will be compromised, because this is triangular shape. Okay, if it was like the gynecoid round, then easily delivery can be done, but in this, as you can see here, anteriorly there is narrowing of the pelvis, due to which if there is occipito-transverse presentation, it can cause deep transverse arrest. Then oval. Then the next type, which is the platypaloid type of the pelvis, and the inlet is oval transverse, and the face presentation can be seen with this. That means the face of the baby will be the presenting part. Okay, then the anthropoid. So this one is the second most common variety seen, and it is the oval. The inlet is oval like this, and occipito-posterior presentation can be seen. So if you are getting confused, let me explain it to you, that this one is the fetal head. So this one will be the occiput, this one is the suture, and here the frontal bone is present. So this one, the occiput, then this one is the suture, and this one is the frontal bone. Okay, so occipito-posterior means the occiput of the fetus, it lies in posterior relation with the female pelvis. So based on the relation of the occiput with the pelvis, we classify it into various types, like the occiput anterior, then the occiput transverse, occiput posterior. So these were some things which you must remember from the pelvis. Look at the images, and also the things like this, the deep transverse arrest, then the occipito-posterior presentation, the male type, and also the inlet. Then moving on to the female pelvis diameter. So the inlet of the female pelvis has three diameters by the name diagonal conjugate, which is 12 centimeter, then anatomical conjugate, which is 11 centimeter, and the obstetric conjugate, which is the 10 centimeter. And then the mid pelvis, it has interspinous diameter, which is 10.5 centimeter. If it is less than 8 centimeter, then it is called as the contracted pelvis. And the outlet of the pelvis, it is the diameter is between the ischial tuberosities. So ischial tuberosities, and it is 10.5 centimeter. Less than 8 called as contracted outlet. Then the fetal skull diameter. So this whole labor thing is very confusing because there are a lot of terms in this, like the presentation, the diameter, then the pelvis, then these stages, everything. Okay, so you need to look at these points 2 or 3 times to come to know and to understand it. Okay, so the fetal skull diameter, it is various diameters present. Suboccipitobrigmatic, as you can see here in the image, the suboccipitobrigmatic. So this one is the brigmatic suture and this one is the occiput. So between them, this is called as the suboccipitobrigmatic, and it is 9.5 centimeter. So as you can see here that the least diameter of the fetal skull is 9.5 centimeter, and the least diameter of the female is 10 centimeter. Then suboccipitofrontal, which is, so it will be from here to here, and it is 10 centimeter. So you need to by heart these names as well as the diameter of it. Then the occipitofrontal, 11.5 centimeter. It's not 12, it's 11.5 centimeter. Then the mento vertical, so this is the mentum and this is the vertex. So this mento vertical, this one is 14 centimeter and it is the largest diameter. Then submento vertical, 11.5, submento brigmatic, 9.5. So whenever there is vertex position, the engaging diameter can be any of the three. So suboccipitobrigmatic or suboccipitofrontal or occipitofrontal. Okay, and whenever there is bro presentation, the engaging diameter will be the submento vertical. So as you can see here that the 14 centimeter is a very largest. So as you can see here that the 14 centimeter, it is the largest diameter of the fetal skull, whereas the largest diameter of the female pelvis is 12 centimeter. So it cannot pass through the female pelvis. So we need to do the cesarean section because normal vaginal delivery is not possible. Then the diameters seen with the face presentation are the submento vertical and the submento brigmatic. So to make it easier, you can just remember the things like this is the face of the fetus, and this mentum gene is called as the mentum, then this is called as the occiput, then the brigmatic suture. So just by keeping these three things in the mind, you can easily understand which diameter is being asked in the question. Then the other diameters are the biparietal diameter, which is this diameter, and it is 9.5 centimeter, 9.5 centimeter. Then the bimastoid, which is the smallest diameter, 7.5, and the bitemporal. So question, this was a PYQ, that which of the following is the smallest fetal skull diameter, and it was the bimastoid. So bimastoid means between the mastoid. So here there is presence of the mastoid and between the two. Okay, so this was the thing related to the labor, the stages, then the diseases like the arrest of the labor, then the presentation, everything. In the next video we will be discussing some other diseases like the placenta, then the antepartum hemorrhage, ectopic pregnancy, everything. Okay, so that's all in this video. So the labor part, it is the most difficult part and the most confusing part from the obstetrics, and I have tried my best to make it easier and explain all the things. Thank you so much for watching this video. Like the video, share it with your friends, and subscribe to GrowMed. Thank you so much. Bye bye.